The attendees.
So, good morning, you all. On behalf of Indian College of Physicians, I want to welcome you all in this short certificate course on allergen immunotherapy. So, Basics of Allergen Immunotherapy is the title of this 6 weeks course, online certificate course. And there will be 6 modules. Today we will have the first module. There are few rules for the completion of the course and getting the certificate. That is number one. There will be class in each week in the Sunday, and attendees will complete one module, which will take approximately 120 minutes. And each module will include pre-test and post-test evaluations, along with panel discussions, and there will be a exit examination, online examination for final certification, and that will be taken at the end, that is during the sixth module. So 100% attendance is required to be eligible for certification, and attendees must achieve a minimum of 60% marks in the exit examinations. So we will start today's session. Before that, I am requesting the Imazika Health, who are the technical partner for this entire course, to please send an email to all the registered delegates, participants, regarding the pre-test questions. So I request all the delegates to check your email. You will get an email from Imagika Health, and there will be MCQ questions in the Google form. You have to submit that within 10 minutes of time. And I think after 10 minutes, no response will be taken further. We'll have the similar type of examination, post-session test, and that will be after the first lecture. And I also request you all to kindly present during the panel discussion and the question answer session, where you can ask the question, drop the question in the chat box, and we will ask those questions to our esteemed panelists. So today we have with us Professor Shantanu Kumar Tripathi, who is a noted clinical pharmacologist in this country. Currently, he is the principal of Netaji Subhash Medical College, Patna. And I'm really privileged to have him with us because he is also my mentor, my guide during the process of my DM curriculum and after that also. We'll also have with us Professor Shoibal Moitro, who is a noted clinician in the field of allergy and immunology. By training, he is a pulmonologist and allergologist. He will also join us during the panel discussion. We are also really fortunate to have the blessings from Professor Jyotirmoy Pal, who is the Dean of Indian College of Physicians. So he will be with us also during the panel discussion, along with Professor Nandini Chatterjee. Madam is currently the Joint Secretary at the Dean's Place. Along with, she is an eminent clinical teacher, professor at Department of General Medicine at the prestigious Institute of Bengal, that is IPGMER and SSKM Hospital. So with that, I think we will start today's session. And as Professor Jyotirmoy Pal is currently at Sri Lanka, Colombo, to join one very important meeting of Sri Lanka College of Internal Medicine Symposium. So I think there is some issues from his side. So we'll take his views, his blessings later. So straight away, we'll start today's presentation. And I am again requesting you all who are joining to check your email. And there is one mail sent by Imagika Health. There will be a link of WhatsApp group where we will discuss about some technical issues and scientific issues regarding this course, along with the pre-test questions that had been submitted to you via that mail. Please go through that mail, go through that link, and you will get the opportunity to participate in that pre-test questions. So without any delay, we'll start today's presentation, that is basics of allergy. So myself, Shambho Shamrat Shomasdar, I had done my DM in clinical pharmacology along with diploma in allergy asthma immunology from International Asthma Service and Bharati Vidyapith University of Pune. So today we are going to discuss about these broad topics. First of all, we need to appreciate the history behind the allergy science. Then we'll discuss about this important concept of atopy, sensitization, and allergy. This terminology we'll discuss. We'll try to understand the basic of immunology and different types of hypersensitivity reactions, mechanisms behind those hypersensitivity reactions. And finally, we'll try to appreciate the management of anaphylaxis. So why anaphylaxis management is important for this course? Because when we will practice allergen immunotherapy, we should be aware of diagnosing anaphylaxis promptly and manage it as early as possible. Yes, anaphylaxis is a very rare complication of allergen immunotherapy, but we need to prepare ourselves for managing anaphylaxis. So when we talk about history, the history of allergy science starts almost 2600 BC, and the first time the documentation was there on anaphylaxis, there were some pictures in the cave, in the pyramids of Pharaoh Menes, and we know that after a wasp sting, he died, and the cause of the death was anaphylaxis. But first case report on allergy was done by this legendary physician, Dr. John Bostock, and he had described the relationship between hay fever and pollen exposure almost 200 years back in 1819. But the term allergy was coined for the first time in 1901 by Clemens von Pilket. And these two gentlemen were very famous in the field of allergy science. They had shown the allergy can be transmitted passively. How they had done? Dr. Kushner was allergic to fishes. So what Dr. Prusnich had done, he had taken serum from the Dr. Kushner, and that serum was injected subcutaneously in Dr. Prusnich's abdomen. And after that, when Dr. Prusnich consumed fish, the area of injection become inflamed. There were triple response, quill-like lesions, and itching. So this was the first time they had shown allergy is something immunological reaction. And in 1923, Dr. Arthur F. Oka and Dr. Robert Hooke had coined this terminology atopy for the first time. And in this picture, we can see three Nobel laureates: Dr. Ischiakus, Madam and Sir Ischiakus, and Dr. S.G.O. Johansson. They were famous because they had discovered IgE for the first time in 1967. So, allergy is an immunological reaction, and this discovery of IgE was crucial, which happened almost 60 years ago. But almost 100 years ago, the Prusnich-Kushner test, that also a crucial finding. Obviously, that carries a lot of ethical issues and infection-related concerns. But for the first time, Dr. Prusnich and Kushner had shown the allergy is an immunological reaction, which was confirmed later by Ischiakus and Johansson. So when we talk about allergy, allergy is an acquired potential for developing adverse reactions that are immunologically mediated to substances that are harmless to most of us. So when we talk about antigen, what is that? The substance that you are allergic to. So it could be the house dust mite, or some pollen, or some food. And when we talk about antibody, what is that? Substance that causes the allergic reaction. So here it is important to note the antigen is not going to cause the symptoms. It is the antibody that is causing the reaction, and that is responsible for symptoms. And most importantly, how you get antibody? Only if you are sensitized. So you need to be sensitized to become allergic. So dust mites, pollens, any foods, they are actually harmless substances. So if there is some altered reaction, so allergy means altered reaction or exaggerated reaction against harmless substances. Very important. What is the basic defect in allergy? The epithelial integrity. The loss in epithelial integrity is the basic defect in allergy. And when we talk about defective barrier, the compromised epithelium, one of the major cause is genetic. And there will be easy entry of the allergens by some environmental factors, and ultimately, like all other diseases, here also we face the gene environment interaction to produce this type of disorders. So as we had mentioned, the basic mechanism is increased epithelial permeability. So as there is defective barrier, the environmental molecules, it could be some allergens, pollutants, pathogens, they will enter into our system easily. And some genetic factors, as we had seen here, and epigenetic changes in the epithelium that lead to increased epithelial permeability. And what are the consequences? There will be facilitation of allergen sensitization. There will be increasing susceptibility of the host by different infectious agents. The tissue remodeling will happen, and ultimately with repeated exposure, the disease will become chronic disease. And what is the type of the inflammation here? We know this is the Th2 mediated reactions. All the cytokines here, like interleukin 5, interleukin 4, interleukin 13, they all are type 2 cytokines or Th2 cytokines. Now, this concept is very important for us. We often use this terminology interchangeably. Atopy, allergy, sensitization. We need to remember they are not the same. Sensitization, that is a immunological state. We'll discuss what is sensitization. But as of now, please remember, this is only an immunological state. Whereas atopy means there is something genetic viscera happen. So this is a genetic state. And when we talk about allergy, that means this is a clinical state. So if I am suffering from allergic rhinitis, I am having symptoms of allergic rhinitis, runny nose, sneezing, itching in the nasal mucosa, that means I have clinical state. So that is allergy. But when we talk about sensitization, it does not mean always sensitization is producing some symptoms. Sensitization means on the top of the muscles, the IgE is sitting on Fc epsilon receptor, but they are not producing the symptoms of allergic rhinitis. I am sensitized, but I am not having any clinical symptoms. So sometimes in skin prick test, you can see there is some sensitization status, that is an immunological reactions happening, but that does not mean you have clinical symptoms. So we need to know it carefully. And atopy means it is only the genetic state. So please be very clear about these terminologies. So atopy, that means inherited tendency to develop allergies. This is a genetic state. This increases your risk of developing allergic disease. One of the very important points is the gene-environment interaction, because this is the basis for allergy to set in. And this is the complex interaction between genetics, epigenetics, and environment. The mutations, the methylation histone modifications by the gene-environment interactions resulting in some epigenetic changes, and all the environmental pollutant starting from some allergens, some drugs, some foods, and most importantly, the gut microbiomes, the helminths, the hygiene hypothesis, all these factors playing their role to determine the phenotype and endotype of allergy. So when we talk about asthma and when we talk about eczema, the atopic asthma or atopic eczema, they are sharing some similarities. And here also, this diagram emphasizing the candidate genetic and environmental interactions, how they are ultimately producing the disease. Very importantly, we talk about the basic defect in allergy is loss of epithelial integrity. So here the gene responsible for epithelial integrity is filaggrin. That loss, that repeated use of soap, repeated use of sanitizers that may cause defect in the epithelial integrity, may cause some epigenetic changes on that filaggrin gene and may be responsible for the eczema. When we talk about atopy and allergy, these are few exceptions, and we all need to acknowledge there are always a few exceptions. You can have allergy without being atopic. The most common examples are insect allergy, drug allergy, latex allergy. So for that, you do not need to become atopic. Your gene may become all right, but you could have the manifestation of allergy. Certain facts, and this is brainstorming. Please read all these 4 sentences and try to understand from within so that the concept become clear. First of all, we can be atopic, but not allergic. So we could have some genetic bizarre state, but we could not have that sensitization or immunological state and the clinical state. You can be sensitized. So your skin test, your skin prick test is showing some positivity, sensitization, but you do not have that symptoms. So you do not have clinical symptoms. So you can be sensitized, but not allergic. You can be allergic, but not atopic. This is an exception, but this may happen. Examples already we had discussed: the latex allergy, the drug allergy, the insect allergy. If you are allergic, you are always sensitized. So this line is very important to understand the basic mechanism of allergy. If I am not sensitized, that means if my IgEs, immunoglobulin E's, are not sitting on top of Fc epsilon receptor over the mast cell, then there is no possibility of having symptoms of allergy. So if you are allergic, you are always sensitized. Your mast cell should have the IgE on top of the Fc epsilon receptors on top of that is present over the mast cells. So that is very important. So when we talk about genetics of allergy, which is very important to note, if one parent atopic, there is more than 50% risk of developing allergy in the children. If both parents atopic, then more than 66% is the risk. But if both of them are not atopic, but there is some risk is present, less than 20%. And it is again important to acknowledge that exact mode of genetic transmission is still not known. So this is unknown. And when we talk about family history, this is the single most important factor for predisposing to development of allergy. What are the risk factors of allergy? Family history of atopy, serum Ig more than 100 IU per ml before age 6 years, animal contact, dust mite exposure, tobacco exposure, diesel exhaust fumes, small family size. These all are the risk factors of allergy. And when we talk about allergy, this is a multifactorial disease. And most importantly, a good history taking is extremely crucial for diagnosis. This picture we need to understand very well to know the mechanism of type 1 hypersensitivity reaction. This we can see the allergen. I'm just taking the ballpoint, moving. So allergens are entering through the defective epithelium, and there is antigen presenting cells here. They are waiting. They will capture those allergen. Sometimes due to the exposure of those allergens, they may produce pro-inflammatory cytokines like interleukin-4, and they will present those antigen or allergen to the naive T cell. And here, how they present those antigen or allergen to the naive T helper cells, they have the MHC class 2 receptors, and T cell has T cell receptors. So in between, they have the allergen. Along with that, there will be an important role of co-stimulatory ligands, so the CD molecules, CD440 ligands like that. Now, by this mechanism, what happened? The T naive cells, they will be differentiated into Th2 cells. And already we had discussed the Th2 cells are the most important characteristics of allergic disorders. So now these Th2 cells, they will have again a crosstalk with B cells. They will produce again some pro-inflammatory cytokines like interleukin-4, interleukin-5, interleukin-13. We know the role of interleukin-5, they will cause eosinophil activation. But this interleukin-4 and interleukin-13, these two cytokines are very crucial. They will tell the B cells, which ultimately produce plasma cells, to have the class switching. We know what happened from the plasma cells. Normally, we'll have the IgM antibodies. But due to this class switching, the plasma cell will produce IgE antibodies. Now, what is the fate of these IgE antibodies? This will remain in the serum, and these will go to the mast cells, to the basophils. Here we can see the mast cells and basophils, they have the receptors, Fc epsilon receptor. And on that Fc epsilon receptor, the IgE will sit, and they will, this stage is called as sensitization state. But this state does not mean the patient will have allergy. When it will be allergy? Again, if there is a re-entry of the allergen through that same defective epithelium, the damaged epithelium, the allergen will be clasped by those sitting IgE on top of Fc epsilon receptor, and that catch will cause degranulation of the cells. The basophil mast cells will be degranulated, and that will cause release of different mediators and results in symptoms of allergy. That is the state, that is the clinical state, and then only we can call it as allergy. So I think now you can understand the difference between sensitization and allergy. Sensitization means the immunological state, but the allergy means the clinical state. So the allergen enters the body, then what happened? The antigen presenting cell takes up the allergen molecule, and they will present its epitopes through those MHC2 receptors onto its surface, and the APC, the antigen presenting cell, becomes activated. They will produce some pro-inflammatory cytokines. Then they will migrate to the nearest lymph node. Now, in the lymph node, who is waiting? The naive T cell is waiting. That this antigen presenting cell with MHC, they will have an interact. The T cell have the T cell receptor, and antigen presenting cell have the MHC class 2 receptors. In between, they have the allergen. Now, this interaction will decide that the T naive cell will be differentiated into Th2 cells. Then what happened? At the same time, that Th2 cells that will interact with the B cells will again recognize the allergen, and then they become differentiated into plasma cell, and there will be some class switching. And already we had discussed the pro-inflammatory cytokines like interleukin 4, interleukin 13, interleukin 5, they have some role in that class switching, and they will produce IgE instead of IgM. And this IgE antibody now recognize the epitopes of the allergen molecules. They circulate, and they, along all those lymphatic channels, cardiovascular systems, that means the blood vessels, finally, they will bind to the Fc epsilon receptor on the mast cells and basophil cells. Again, there is a re-entry of allergen at a later time, and it binds to the Ig, which is on the cell surface, and resulting in an aggregation of the receptor, causing the cells to release the preformed mediators like histamine and other. So again, this is the picture. Again and again, we need to revisit this concept of type 1 hypersensitivity reactions to understand the basic of allergy. So again, A, B, C, D, you can see the A, that means the allergen through the defective epithelium, they enters into the tissue, and there is antigen presenting cell, and antigen presenting cell will take them to the lymph nodes. The T cell is waiting, T cell receptor, MHC2 receptors from the APC, and there is a presented antigen, the role of co-stimulatory ligands. Then ultimately the T cell, which was naive, that becomes the Th2 cells. The Th2 cells will produce cytokines, pro-inflammatory cytokines, interleukin 4, 5, 13. Again, the Th2 cells have reactions with the B cells. The B cell will be presented the antigen. The B cell will recognize those antigen, and they become matured, produce plasma cells. Plasma cells will release IgE due to the class switching. Again, the Ig will come back to the tissue and then circulation. They will sit on top of the mast cell. This is the stage when we call it as sensitized state. Again, with the release of allergen, antigen, there will be on the top of the Ig, they will come and they will degranulate the mast cell. They will produce histamines and other mediators. So what causes allergy? This is a two-step process. The first step is sensitization, and second step, when there is a liberation from the mast cells, the different mediators, there will be allergic reactions. So that is why we have two phases of allergic reaction. The early phase, that will be within minutes and maybe last for 1 to 2 hours. Examples are local reactions. It could be some redness, swelling, itching, what we had seen in the skin prick test response. And in case of systemic, there could be a symptoms of anaphylaxis. Late phase generally starts 2 to 6 hours later and peaks around 9 to 12 hours. That causes inflammation swelling, redness, and different secretions. So when we have the chronic allergic inflammation, that means we have repetitive exposure to allergens. These are difference between early versus late reactions. Early phase, that means the main cell is mast cells here. Response within minutes to 2 hours. But late phase is 2 to 8 hours after. Predominant cells involved here are the lymphocytes, neutrophils, and basophils. So for early phase, the histamine is the main mediator, preformed histamine. And also, it will be the prostaglandins and leukotrienes, which will be formed. But in case of late phase, there will be a multiple mediators. So in the early phase, which is generally the histamine, the role of antihistamines are there. But to control the late phase reactions, we need anti-inflammatory drugs. It could be steroids in forms of local or systemic. Now the question is like that. This is a very famous question often asked by my mentor, Professor P.K. Vadantan, who is a very noted allergologist in US, Colorado University. Which is the conductor cell in the allergic orchestra? I think now you all will be agreed. The answer is lymphocytes, the T lymphocytes. It is not the eosinophil, it is not the mast cells or basophil. Now coming to the IgE production, little bit basics of this IgE production. So we now appreciate that it is the T cells that control IgE production. The T cell commands the B cell to produce IgE through cytokines. The most important cytokines are interleukin 4 and interleukin 13, which is generally produced by the Th2 cells. And what is the function of Th1 cells? That will inhibit the IgE production through interferon gamma. So there they will produce interferon gamma, the Th1 cells, whereas the cytokines like interleukin 4, interleukin 13, they will cause IgE production. So this is a single 4-chain unit of molecular weight of 180,000, very low concentration in normals. And that is why its measurement is very much assay dependent. And this will not activate the complement system, will not pass through the placenta. And actually, we do not know about what is its normal beneficial function. There are certain hypotheses, because IgE can be divided into maybe 4 types. But it is important to acknowledge in the fetus between 8th to 10th week, the production of the IgE begins. Generally, when we talk about IgE less than 2 years, they are directed against foods. And if it is more than 2 years, they are generally directed against aeroallergens. Sometimes you may do a allergy test, that is serum allergy test, to estimate the specific IgE in a children, in some child whose age is 1.5 years. And you will find a report, and there you will get the child is, the plus sign is there with maybe potato, maybe some other foods, brinjals, some meat, something else like that. And the mother will tell you, my child is not eating this type of food. How this becomes positive? So it is important to note, even if the mothers are handling those food items in the kitchen, and through the skin, through the contact, that may enter into the children immune system, and that may produce this type of sensitization. But again, we need to remember Here, the sensitization does not mean the patient is having allergy to those food. To determine that the patient is having allergy, we need to confirm it by again taking the history, again confirming with the patient's symptoms with those allergen exposure. When there is high level of IgE, it is important to note again, it is not always associated with allergic disorders. And even in allergic patients, we often found normal IgE level. And there are lots of other causes where IgE could be elevated. It could be Epstein-Barr virus infection, some parasitic diseases, which is very common in our country, some hyper IgE syndromes, recurrent staph, skin abscesses, pulmonary infections, malignancy and smoking, that also may cause high level of IgE. So IgE is very much non-specific for allergy disorder. And when we talk about natural history of allergy, it is important to acknowledge this march, the allergic march, the progression of the disease. This is a disease which have some genetic susceptibility, environmental factors as already discussed, and some risk factors like small family size, early use of antibiotics, which may cause destruction in our good gut microbiome environment, and that may lead to allergy. Western lifestyle, diet, passive smoking, these all may be responsible for us, for Indian population now to enter into the first phase of allergy epidemic. So already we know the first wave of allergy epidemic had been started in India. And we need to know allergy is not a cross-sectional disease or snapshot-like disease. We will provide some treatment for 15 days, 1 month, it will be finished. Not like that. This is a progressive disease. And also important to acknowledge this concept, we will not outgrow allergy soon. When I was young, when I was 9 years, 10 years old, I had a severe allergic asthma-like symptoms. I have cough variant of asthma. That time, my treating physician told my mother, when he becomes 12 years, 13 years, 14 years, the allergy will be gone, do not worry. This concept is now not true. So we need to address this very cautiously. We need to educate our patient very cautiously. And that is why we need to increase the awareness on allergen immunotherapy, because the allergen immunotherapy is the only modality which may have some impact on altering the natural history of allergy. So this is a classical picture of atopic march. So first manifestation is eczema, followed by food allergy. Then we'll have the symptoms of asthma and rhinitis following that. And we can see how they reach the peak and they maintain. So this is a classical features of atopic march. So a baby, an infant who may present with eczema, subsequently who will develop food allergy at the age of 3 to 4 years. Then he will develop asthma, maybe 5 years, 6 years like that. And then after 10 years, he will also develop the rhinitis. So this is the natural history. Yes, there could be some exceptions. There is a possibility of manifestations of disease, sometimes rhinitis early, followed by asthma. Sometimes eczema can be later. So that can be possible. But this is the natural phenomenon, the atopic march. And when we talk about allergic diseases, we the nomenclature actually based upon the target organ and the antigen. That means the allergen. So if it is nose, then it is rhinitis. If the target organ is eye, then it is conjunctivitis. If it is lungs, then it is asthma. If it is skin, then it is dermatitis or eczema. And depending on the antigen or allergen, we can call it as food allergy, drug allergy, insect allergy, or latex allergy. So site determines the clinical response. So these all are different types of allergic diseases. Now coming to the diagnosis of allergy. It is again, we need to appreciate the history as a most important part of diagnosing allergy. Physical examination may be normal, may be abnormal. Allergic skin testing is important. This is a sensitive test. But again, when we talk about allergy skin test, this is only an immunological test. This is only which will tell us the sensitization status of the patient, not allergic skin test is telling us the patient is suffering from certain allergy. So we need to correlate with history for final interpretation of allergy skin test. So history needs to be thorough and needs to be correlated with skin prick test. Again, it has some diurnal variation, and this is a classic characteristics of allergy. And I think many pediatricians use peak expiratory flow rate PFR values to diagnose asthma. And when we talk about all the allergy, they are in general the nighttime disease. And we need to acknowledge the chronobiology and chronotherapy while managing our allergic patients. So always inquire regarding the nocturnal symptoms, the sleep pattern when you evaluate allergic disorder. And nowadays, the sleep science is evolving, and there were lots of studies which suggest there is a correlation between obstructive sleep apnea and allergic rhinitis too, and asthma too. So allergy epidemic, whether it is fact or fiction, it is now happening in India. Already we had discussed it. India is entering into the first phase of allergy epidemic. The prevalence is increasing worldwide. So what are the several factors behind that? Most importantly, the lifestyle, urbanization, population migration, our diet, activity, obesity, pollution, the diesel exhaust, indoor allergens, the climate change, outdoor allergens. We have nuclear families. The same hygiene hypothesis is there. Hygiene hypothesis is there with many other diseases here also in the allergy also. The C-sections, the antibiotic overusage, these also prevent the localization of good gut microbiome in the babies. So ultimately, the gut axis, the gut-lung axis become impaired. And due to having some bad gut bugs, our immunological system become altered. So when we talk about immune system, generally, our immune system is built to fight against non-self. Do not fight against self. That is the principle of immune system. So that is why our immune system destroy the self-reactive immune cells. And that is the central tolerance. Mainly we have lymphoid organs like thymus, which produce T cells, bone marrow, which produce B cells. And if there are some self-reactive B cells or T cells, they will escape and they will attack cell. And that results in autoimmune disease. So when we talk about hypersensitivity, what we know, generally our immune system is there to protect us. But instead of protection, if they are damaging us, that is the hypersensitivity reaction. Now we'll discuss about 4 types of hypersensitivity reaction. This picture already we had discussed multiple times, the type 1 hypersensitivity reaction. So in the type 1 hypersensitivity reaction, 2 important steps. One is sensitization, and after sensitization, when again re-entry of the antigen or allergen, they will cause the mast cell destruction and release of mediators like histamines. So degranulation of the cells, a release of histamine, other proteolytic enzymes, different mediators like prostaglandins, cytokines, leukotrienes, platelet activating factors, macrophage inflammatory proteins, tryptase, and that will result in all those symptoms. And if those symptoms are present, that is the clinical state is there, then we can call it as allergy. In case of nose, it is allergic rhinitis. In case of eyes, it is allergic conjunctivitis. If it is systemic reactions, life-threatening medical emergencies, then it is anaphylaxis. So after that, what is type 2 hypersensitivity reaction? So for the type 2 hypersensitivity reaction, let's focus on this cell. The cell, they have the antigen which is sitting on top of the cell. Now they will invite IgG antibodies. Now these IgG antibody and the antigen, this complex, but this is not the typical complex which we will discuss about when we will learn about the type 3 hypersensitivity. But this complex will invite natural killer cells. So that will cause killing of those cells on top of that which the antigen is sitting. Another mechanism is that here again we can see the antigen. Now IgG antibody is there. So they will invite the complement system, and killing of target cells here will be by complement mediated lysis. But I think all of us once upon a time had been taught type 2 hypersensitivity reaction. Another name is cytotoxic reaction. Not always this is cytotoxic, because here on also you can see on top of the cell, the receptors are there, and on the receptor, the antigen is sitting on top of that, and they will invite the antibodies. So receptor-specific autoimmunity, which will ultimately interfere with the signal transduction. If it is hyperactive, then it will cause diseases like Graves' disease. If it is hypoactive, then it will cause diseases like, in case of acetylcholine receptor, if it is hypoactive, that will cause diseases like myasthenia gravis. So type 2 hypersensitivity, there is one mechanism which is cytotoxic, but another mechanism is also there which is not cytotoxic. So in case of cytotoxic, what we had discussed, the self-reactive B cells will produce IgM, or with the help of CD40 helper cells, they will produce IgG. And this IgM or IgG will attach us to the antigen, which is sitting on top of the host cell, that is the cell. And this antigen, it could be intrinsic or it could be extrinsic. Extrinsic means it could be some drug, it could be some virus, bacteria, proteins. Now this antigen antibody complex will, on the host cells, they will activate complement system. What is complement system? They are small proteins. They will produce enzymatic cascade, and generally they are for helping us to fight against infection. But here what they will do, this antigen antibody complex, when attaching with the first complement, that is C1, the other complements like C2 to C9, they will be cleaved and activated. And the most important chemotactic factors are activated C3, C4, and C5. which will attract the neutrophils. They will degranulate neutrophils. They will produce enzymes like peroxidase, myeloperoxidase, proteinase 3. They will produce lots of free oxygen radicals. We know the diseases like autoimmune hemolytic anemia, where we have extrinsic antigen like penicillin, that will also cause neutropenia, thrombocytopenia, some ceftriaxone-induced thrombocytopenia, similar mechanism of this autoimmune hemolytic anemia. In case of intrinsic antigen, that means when the collagen of basement membranes, maybe from the glomeruli or from the alveoli, they will act as intrinsic antigen. They will produce disease like Gut-Pasteur syndrome. So these are classical example of type 2 hypersensitivity reaction. So what happened? They are cytotoxic to tissues. The complement system, they will fall on. The other, like C5, C6, C7, C8, along with C9, they will form a polymers and they will create a hole in the cell. And that is known as also as membrane attack complex. And these membrane attack complex will attack the cells by producing a big hole in the cell membrane, and that will cause damage, that will cause cell lysis. The examples are acute rheumatic fever, the streptococcal antigen, which is structurally mimic the cardiac myosin. And already we had discussed, there are certain examples where autoantibodies bind to the receptors on target cells, causing dysfunction without causing inflammation or destruction. Graves' disease, myasthenia gravis, classical example of type 2 hypersensitivity reaction where there is no cytotoxicity. Coming to the type 3 hypersensitivity reaction. We know this picture, classical picture of type 3 hypersensitivity reaction. Here we can see the antigen. This is the antibody. The locally injected antigen with antibody IgG, they will form a local immune complex. What is the difference with this antigen-antibody complex and the type 2 hypersensitivity reactions antigen-antibody complex? That antigen-antibody complex, which happen in type 2 hypersensitivity reaction, that will be on top, that is bind on the cell. But here it is not bind on the cell. They will cause some immune complex which can circulate through the vessels, and they will activate some Fc gamma cells, which will produce ultimately the inflammations when they will gather all together, and they will produce local inflammation and phagocytosis. So this is an immune complex mediated reactions. Antigen-antibody complex will deposit in the blood vessel wall. They will produce inflammation and tissue damage, which will be mediated by antigen-antibody immune complex. So production of IgG, what we know already, the antibody will produce, which type of antibody will be produced by the plasma cells? IgM in general. So these B cells surface bound IgM that will act as also the B cell receptors. So what happened? Two surface bound IgM. Just think about that picture when we talk about mast cell and on top of that the IgE was there. Here we are talking about IgM cross-linking on B cells, which will take up the antigen, modify, and ultimately present to T helper cells via same T cell receptors. And the MHC class 2 molecules used by B cells to present antigen here. The CD40 ligand. So from the B cell, the CD40, from the T cell, the CD40 ligand, they will have some co-stimulatory reactions, binding, and that will cause T cells to release cytokines. Here it is interferon gamma. The B cells, they will have some class switching here. By this interferon gamma, they will produce IgG not the IgM. And this IgG will recognize antigen. So soluble antigen or cell surface bound antigen this is. And this immunocomplex, what we are talking now in the type 3 hypersensitivity reaction is soluble antigen plus IgG. Now, when we talk about cell surface bound antigen plus IgG, that is in case of type 2 hypersensitivity reaction, that is not an immune complex. In this case, we are talking about immune complex, and that is the soluble antigen plus IgG. We know the classical example SLE, the IgG antibody specific for DNA nucleoproteins. They become self-reactive, and they are the autoantigens, the complement used in large amounts, both the C3, C4. So when it is small antigen antibody complex, so they are obviously less immunogenic. So they will float around blood longer as less attractive. They are very less attractive to other immune cells. So they will deposit in the basement membrane of blood vessels. And ultimately, they will activate the complement systems. Again, the C1 attach the complex reaction starts, C2 to C9. It's the same anaphylaxis like C3A, C4A, C5A. They will cause increased vascular permeability, and there will be fluid leaking out, producing edema. The C3A, C4A, C5A, these anaphylaxins, they also act as chemokines. They will recruit neutrophils to that site and try to phagocytosis the immune complex. And if there is unsuccessful phagocytosis, they will degranulate. There will be lots of lysosomal enzymes, lots of reactive oxygen species that will cause inflammation, tissue necrosis, which results in vasculitis, a classical feature in type 3 hypersensitivity reaction. So further cell will destroy. And if the cell is destroying, what we will have? We will have more autoantigen. So ultimately the cycle will be repeated. The vicious cycle will be going on and on. These are the common sites. We know in case of SLE, the kidney, joints, the serum sickness, previously type 3 hypersensitivity is also known as serum sickness like illness. So there the foreign serum are responsible for antibody response. We know when we manage the snake bite cases, the anti-venom antibody that will bind to the antibody to the venom antigen and producing those immune complex, and that may result in vasculitis. Finally, the last part of hypersensitivity reaction, the type 4 hypersensitivity reaction. Again, it has a sensitization phase and effector phase. Just like the type 1 hypersensitivity reaction, there the antigen presenting cell and the T-naive cells interaction will result only the Th2 mediated reactions. But here they will produce either Th1 or sometimes in this case also they will produce Th2 reactions and so on. And that cell will produce some specific cytokines and ultimately activate the macrophage. So this is also known as delayed hypersensitivity reaction. So when we talk about delayed hypersensitivity reaction, this has a crucial role in our body's ability to fight various intracellular pathogens like mycobacteria, fungi, and also they have a very important role in tumor immunity and transplant rejections. So unlike the other hypersensitivity reactions which are mediated by antibodies, type 4 involves antigen-specific effector T cells. So there is a role of effector T cells. So as this is an effector T cell mediated reaction, does not occur until 24 to 72 hours after exposure of a sensitized individuals. And this is why this is also known as delayed type of hypersensitivity reaction. So the delay is due to the time required for T cell differentiation, cytokine and chemokine secretion, accumulation of leukocyte at the sites. So there is one sensitization phase where we have uptake, processing, and presentation of the antigen. Then the antigen presenting cells like dendritic cells or macrophages, they will recognize those antigen and present to the Th cells, and T cells become primed. Now in the second phase, the effector phase, which is cytokine mediated, antigen on the surface of the antigen presenting cells recognized by the primed Th cells, and antigen presenting cells, they will produce some cytokines. Here it will, if it is Th1 cells, then the interleukin 12 will be produced, which cause induction into the Th1 cells, and these Th1 cells will produce cytokines like interleukin 2, which increase T cell production of Th1 cells. Interferon gamma will recruit macrophages, TNF, which that is increase the vascular permeability, and more leukocytes will be recruited, and release of inflammatory mediators. It could produce cellular damage, then the tissue injury. And as there is a persistent antigen stimulation, just like in you think about tuberculosis, the granuloma will be formed. So antigen could not be phagocytosed. So the immune system attempts the wall of the area. So it is due to that immune system reaction, the natural phenomenon is to produce this granuloma. If the macrophages become elongated, then it is epithelioid. If it is fused, it will produce Langerhans giant cells. So more lymphocytes are recruited with fibroblast forming a world of ball formation. There is also a possibility of direct cell cytotoxicity. We know the CD8 plus T cells, they are the cytotoxic T cells. They release cytotoxins. Then they will kill the targeted cells, and that will produce tissue injury. As we are talking about type 4 hypersensitivity reaction, again, we can divide type 4 hypersensitivity reactions into 4 groups, A, B, C, D. A means where there is macrophage activation. B means when the primarily this is eosinophil mediated reactions, and type 4B is almost synonymous like type 1 hypersensitivity reactions. And that is why we can see here the disease like chronic asthma, chronic allergic rhinitis, even the maculopapular exanthema with eosinophilia. They are the example of type 4B hypersensitivity reaction. And when there is T cells, the cytotoxic T lymphocytes, they will produce contact dermatitis, maculopapular, bullous exanthema, hepatitis. And when that is soluble antigen presented by direct T cell stimulation, which will recruit neutrophils, and that will produce Behçet disease or AGEP. So in nutshell, when we talk about different types of hypersensitivity reaction, I think this is a beautiful paper by Hosman et al., who had reviewed all those types of hypersensitivity reactions in very simplistic way. I am requesting all the delegates to go through the net, and you can check this reference later, and you can download this paper. This is a very nicely written review article. Now we are moving to a last part, that is the anaphylaxis management part. So just a quiz, just think the answer and try to write down those answer in the chat box. What is the commonest cause of fatal anaphylaxis? Any wide guess? The answer is drugs. Now, true or false? Anaphylaxis is poorly diagnosed and underdiagnosed. So it is poorly diagnosed and underdiagnosed. Is it true or false? I think yes, you all should agree this is a true statement. Anaphylaxis is poorly diagnosed and also underdiagnosed. The first question was, what is the commonest cause of fatal anaphylaxis? So commonest cause of fatal anaphylaxis, drugs. But most common cause of anaphylaxis, what will be your answer? Yes, the answer is food. Food is the most common cause of anaphylaxis. So a 12-year-old boy came into your emergency room, stung by a bee. He had been playing well. Initially, complained of localized pains and swelling, but 15 minutes later, developed shortness of breath. The parents observed him. They were wheezing. The patient become very weak and dizzy. These are the clinical findings. Respiratory rate is high, tachycardia, blood pressure is falling down, mild respiratory distress, drowsy and pale, but awakens when you talk to him. Generalized urticaria is there, but no conjunctival edema. Lips and tongues are not swollen. Voice sounds normal. Tachycardia is there without murmur. Mild wheezing is there. Minimal retractions are there. Abdomen is soft and non-tender. Face is moderately pale. And you also can see the bee sting site on his right forearm, but that is unremarkable with no foreign body seen. To define the case, we need to understand the anaphylaxis. We need to know about how to diagnose anaphylaxis and what should be our treatment. So this is a serious, rapid in onset, systemic hypersensitivity reaction characterized by life-threatening compromise in airway, breathing, or circulation with presence or absence of dermatological features or circulatory shock is defined as anaphylaxis. Mostly this is type 1 hypersensitivity reactions, but there are certain conditions which may cause non-type 1, non-IG mediated anaphylaxis. So first of all, we need to understand the symptomatology. The most important line is the anaphylaxis should have a sudden onset of following symptoms. So this sudden onset is very important. So this will cause skin or soft tissue involvement, mucosal involvement, flushing like pruritus, hives, swelling, pruritus, often involving lips, tongue, uvula, palate. There could be a periorbital pruritus, which is associated with or without erythema, and also swelling conjunctival erythema, tearing pruritus, external auditory canal, genitalia, palms, and soles. These all are symptoms of involving upper and lower respiratory tract. Again, starting from pruritus and congestion in nose, rhinorrhea, sneezing, larynx involvement, which may cause symptoms like hoarseness, pruritus in throat, dry and staccato cough. The stridor, difficult in swallowing, and dysphonia. So pulmonary involvement leading to breathlessness, chest tightness, deep cough, wheeze, bronchospasm. And obviously, if you have the possibility to check the peak expiratory flow, that will be decreased, and in late stage, it will produce cyanosis. The gastrointestinal tract symptoms are very important. Cramping pain in abdomen. It is important to note, even in absence of food allergen, it could be some bee sting bite or some drug injected that also may result in cramping pain abdomen. And that is a classical feature of anaphylaxis. These all are the cardiovascular symptoms, which starts with chest pain, palpitation, arrhythmia, to fainting attacks in both mental status alteration, urinary fecal incontinence, shock, and ultimately cardiac arrest. Nervous system, the classical symptom is impending doom, aura, uneasiness, tunnel vision is very important here. And when we are seeing our patients who is suffering from anaphylaxis, we should not have tunnel vision. Otherwise, we will miss the diagnosis of anaphylaxis. Sudden behavioral changes in infants and children, specifically the irritability. Suddenly, the patient will stop playing, clinging to parents. So these are very important in pediatric population. And these are some miscellaneous symptoms like metallic taste, dysphagia, uterine contractions in postpubertal females. But the most important slide, I think, is this slide, the diagnosis of anaphylaxis, we should follow this guideline, WAO guideline, World Allergy Organization, the latest 2019 update on anaphylaxis. There is anaphylaxis is highly likely when any one, this 1 and 2 you can see, this 1 and this is 2. So any one of the following two criteria are fulfilled. So the first criteria, acute onset of illness, minutes to several hours, with simultaneous involvement of skin, mucosa, or both. So acute onset, then involvement of skin, mucosa, or both. Like it could be generalized hives, growths, flushing, swollen lips, tongue, uvula. Along with that, anyone, at least one of the following, with this plus any of these three ABC, either it would be respiratory compromise, the patient may tell they have dyspnea, wheeze, bronchospasm, stridor, reduced PF, hypoxemia, or it could be reduction in blood pressure or some other associated symptoms like hypotonia, collapse, syncope. Sorry. Sorry. But third point is also important. That is severe gastrointestinal symptoms, severe crampy abdominal pain, repetitive vomiting. Why I am telling you? Again, you please note down this line. After exposure to non-food allergens, even with drugs. So one of my patients very recently, with one of the drugs, the patient was consuming for 3 days or 4 days, tell me certain, the patient was presented at the emergency with urticaria, along with the patient is having the severe pain abdomen. So the patient not given the adrenaline, and after 3 hours, 4 hours of the initial presentation, he died. So this can be happen. These fatal events can happen if we delay the diagnosis of anaphylaxis. So this is the number one criteria. What is the number two criteria? Again, that is very important. You just check the or word. So either it is acute onset hypotension, or it is bronchospasm, or it is laryngeal involvement. Any one. But after exposure to a known or highly probable allergen for that particular patient, and also we know the temporality, the minutes to several hours. So even in the absence of typical skin involvement, so we know that one child may be having a history of peanut-induced peanut allergy. Now the patient came to you with severe wheeze. There is a history of having peanut ingestion maybe 1 hour back, but patient does not have any skin reaction. So whether you will treat the patient as anaphylaxis or not, yes, you should stamp that case as anaphylaxis, because there is bronchospasm, and you know there is an exposure to a known allergen for that particular patient within 1 hour. So minutes to several hours. We know the temporality is matching. So the diagnosis should be there. Even there is no typical skin involvement. So this slide is one of the most important slide of today's presentation. So again, for children, we know this is the definition of hypotension. So actually, by diagram, we can see this is the skin rash is there, skin involvement, mucosal involvement is there. Any of the following. It could be airway symptoms, it could be circulatory symptoms like blood pressure fall or hypotonia or syncope, or it could be severe gastrointestinal symptoms. Anyone with skin eruption, skin rash, mucosal involvement or mucosal involvement will stamp the case as anaphylaxis. Or we know there is an acute onset of hypotension, or the patient is having bronchospasm, or the patient is having laryngeal involvement after exposure to a known or highly probable allergen. Even the patient does not have any skin involvement. You can see no skin involvement is there, but we need to stamp the case as anaphylaxis. So what are the causes of anaphylaxis? I think there are different foods which can cause anaphylaxis in an IG-dependent mechanism. There could be a delayed anaphylaxis to red meats, known as alpha-gal syndrome, which is also IG-mediated. This is a picture. This picture is taken from NEGM. I am again requesting you to read this full paper, very interesting paper. So once there will be a tick bite that will produce IG antibodies and against the alpha-gal. And if the human is eating some red meat, which also contain the alpha-gal carbohydrate, that may produce a delayed reactions and secretions of different mediators by activated basophils and mast cells producing the anaphylaxis. So IG-dependent anaphylaxis could be from venom, from drugs, from allergen immunotherapy, and also some rarely inhalants like horse, dog, cat dander, grass pollen, even the human seminal fluid, which can contain the prostate-specific antigen that may lead to anaphylaxis, IG-dependent anaphylaxis. The IG-independent immunological triggers, it could be high molecular weight dextran, monoclonal antibodies, the large molecules like infliximab, non-immunological triggers like medications, opioids, NSAIDs. These all may cause IG-independent anaphylaxis. When there is idiopathic anaphylaxis, so there is a possibility of unrecognized trigger, or there could be a rare possibility of mast cell activation syndrome or monoclonal mast cell disorders. We need to acknowledge the risk factors and cofactors. So atopy is a very important risk factor. And food, latex, exercise, radio contrast media, and idiopathic anaphylaxis are strongly correlated with presence of atopy. Two extremes of age, adolescents and geriatric population, they are at better risk of severe anaphylaxis. And pre-existing disease like asthma, COPD, interstitial lung disease, mastocytosis, mast cell disorders, depression, psychotic disorders, cardiovascular disorders, they are associated with severe anaphylaxis. What are the cofactors? There are certain cofactors we need to acknowledge: fever, upper respiratory infection, emotional stress, menstruation, exercise, alcohol intake, drugs like beta blockers, alpha blockers, SE inhibitors, tricyclic antidepressants like amitriptyline, MAO inhibitors, ADHD drugs, they all increase the severity of the anaphylaxis. And there are certain drugs like sedatives, hypnotics, antidepressants, and some recreational drugs, alcohol, which may affect the diagnosis of anaphylaxis, leading to delayed recognition, where we always advocate in early recognition of anaphylaxis. So identifying the cause of anaphylaxis is extremely important to prevent future exposure. So detailed clinical history that will guide the physician to understand the likely trigger and thorough the temporal evaluation of the exposure. It could be drugs, insects, food, along with the cofactors like exercise or alcohol intake could often identify the cause. For an example, weight-induced anaphylaxis. many times is associated with exercise. So patient took some wheat-based breakfast, went to gym, and that will result in anaphylaxis. So this is a common scenario behind anaphylaxis. So when we have anaphylaxis, first of all, we need to diagnose it at earliest. And before doing any test, we need to use adrenaline. That is the lifesaver. So A for A, we should not delay the another A if there is one A, that is anaphylaxis. So we need to start adrenaline at earliest 0.5 milligram intramuscularly. Sometimes it may require repetition, and we need to train our patient relatives regarding the adrenaline injection, how they can store adrenaline. I think we can take a separate class on or separate video we can share with you all how we can have adrenaline in hand, because we do not have till date the EpiPen like our Western countries. So tryptase, someone may do that tryptase, but it has limited value, because if we want to confirm the diagnosis, the tryptase value should be done within 30 to 180 minutes of symptoms onset. Before that, there is no rule. And if it is elevated, again, we need to check it after 4 to 6 weeks. If still it's elevated, then we need to check that KIT mutation to find out any muscle disorders are there or not. And if it is not, then we need to search for triggers. After 4 to 6 weeks, we may need to do the skin test, because if we do it within 4 to 6 weeks, that skin testing does not have any value. What test we can do? We can do component result diagnostic before that. But generally, we should do the skin test at least after 4 to 6 weeks of anaphylactic effects. So immediate intervention, as already we had mentioned, after securing the ABC, we need to administer epinephrine at earliest. And the dose is there. And apart from that, depending on the response to epinephrine, we need to decide how we behave. The placement is important. That should be a recumbent position and elevate the lower extremities. We need to give sometimes oxygen if the saturation is falling. The IV fluid replacement is required. But the emergency thing is, again, we need to repeat the adrenaline. The diphenhydramine, ranitidine, glucocorticoids, they are the later means. So glucocorticoids should never be used in place of or prior to epinephrine, because that will not helpful acutely. So first we need to give adrenaline, and adrenaline. So initial drug of choice is epinephrine or adrenaline, and where we should give the ideal intramuscular injection should be given with the vastus lateralis. The intramuscular is important, but if it is not, we can also give subcutaneously. Every 5 to 10 minutes as necessary, as soon as the diagnosis of anaphylaxis is suspected. And the concentration is here, it is important for adrenaline, that is 1:1,000. What is physiological antagonism? So in this case, the adrenaline is a physiological antagonist to histamine, which is responsible for the primary symptoms. Obviously, the other mediators are there. But sometimes adrenaline is not effective, especially when the patient is consuming beta blockers. So that is the time when we use glucagon injection. And along with we need to have the isotonic volume expansion. Here it is important to note, the glucagon we are using here, they are also physiological antagonists. To whom? To the beta blockers. And that is why the glucagon has a very important role when the patient is on beta blocker and not responding to adrenaline. First, we need to give adrenaline. If it is not responding, then we need to use glucagon, because that glucagon will reverse the refractory bronchospasm and also the hypotension during the anaphylaxis in patients on beta who are consuming beta blockers by activating the adenylyl cyclase directly and bypasses the beta receptors. So as already we had mentioned, the positioning of patient, it should be the supine position. Only thing is important, we should not allow the patient to remain upright sitting position prematurely. We need to educate the patient and the patient relative or the caregiver who are surrounding the patient. Another important time, when we are using glucagon, we need to tell the patient, we need to make the patient turn in one side, because we all know the one of the side effect of glucagon is vomiting. Because in case of supine position, if the patient vomits, there is a chance of aspiration. So that is why we need to make them in one side. Oxygen is important, as already we had discussed when it is important. The fluid resuscitation, if it is persisting hypotension, we need to use fluid judiciously. And other medications, there are the roles of inhaled beta-2 agonist, vasopressor, diphenhydramine, which is an anti-H1 antagonist. The dose is 25 to 50 milligram intramuscularly. But often what we do, when we see the anaphylaxis patient, we are diagnosing anaphylaxis patient, but without giving adrenaline, we are giving diphenhydramine first and then glucocorticosteroid. So our practice need to be changed. The first is again adrenaline, then the other things. So late phase reactions can occur 4 to 6 hours after the initial reaction and can be as severe as or worse than the original reaction. And in some cases, late phase reactions can occur up to 72 hours later. So the education is extremely crucial here. The patient should be observed. Long-term management that includes identification of the triggers, again, detailed history taking. We need to do the confirmatory test in later time. Written anaphylaxis action plan we need to give to the patient or caregiver. The availability of the epinephrine as an auto-injector for prompt administration as early as possible. So I'm just going through this, and today's take-home message is, first, I think we all should agree now, atopy, sensitization, allergy, these three terminologies are not same. T cell, that is the conductor in the whole allergic orchestra. And when we know about type 1 to type 4 hypersensitivity reactions, we understand how our immune system is becoming reactive to self. And for anaphylaxis, the early identification and initiating adrenaline is the key step. So with that, I want to thank again. I want to acknowledge especially my teachers for this particular presentation, Professor P.K. Vedantam, Professor Shoibal Moitro, Professor Shantanu Kumar Tripathi, Professor Nandini Chatterjee, and Professor Jyotirmoy Bal. So thank you. We will take some questions, and also we will have some panel discussions. And we have with us today Professor Shantanu Tripathi. I think we will take some questions from the panelists, but at the same time, I request all, you will get another mail now from Imagika Health for the post-test questions. So for the post-test questions, you please again fill that Google form and submit your response. All the correct answer will be discussed, will be given in the WhatsApp group. Already the link of the WhatsApp group had been sent to you all in that particular registered email address. So you can join the WhatsApp group via that link, and we'll try to discuss your queries also there. we'll take your comments also there, and also we'll give the correct answer of today's pre-test, post-test questions in that WhatsApp group only. So I'm requesting Imagika Health to please send again to all the attendees the post-test questions. Please send them an email on the post-test questions, and I am requesting you, when you are listening us the panel discussion, please try to finish the post-test, and when we will finish by 12 or maybe 12:10 like that, your link will be not active that time. So please try to answer your post-test questions. So I think we have with us Tripathi sir. Sir, are you there, sir?
Yeah, I'm there. Good morning.
Good morning, sir. Thank you for staying with us. I know because of there is some more time we had taken, but thank you very much, sir, for your stay. So I want to start uh, my question to you, sir. Before that, I want to take your comment on this topic, and especially what you want to tell our delegates about this basics of allergy, especially in the context of allergen immunotherapy. Over to sir.
No, it was really a wonderful experience listening to you. It was quite comprehensive. You have started with the very basics of allergy, and then you have gone to the different hypersensitivity reactions, their position, the underlying subcellular mechanisms in the pathogenesis of allergy, and you have very nicely given examples also to appreciate and comprehend the concepts, and and then you went on to discuss the specific types, particularly types of hypersensitivity reactions, type 1, 2, 3, and 4. And I think it was very meaningful and useful to all the participants today. uh, it is very worthwhile to have this introductory today. I think it's a 6-week course, and it is very apt that you started with this first module, uh, appropriately conceived and designed. Uh, I hope the subsequent modules will be also equally clear, and the first module particularly will help us to develop our insights so that we can follow the subsequent modules in this 6-week course, which will be happening, as I understand, every week. There will be a couple of hours on every Sunday. So I hope all the participants today have listened attentively. It was very engaging, uh, and I am sure they, if there are some issues, there are some questions, comments, they must be writing them in the chat box, which we can discuss it further. Okay, and I must congratulate Dr. Shambo to have this first module, introductory module, and you have done a great job. You have done justice to the topic. Definitely, congratulations, Dr. Shambo. Thank you.
Thank you, sir. Thank you. Thank you very much for your encouraging comments, sir. So before I will take some question from the delegates, I'm requesting if you have any questions in your mind, you can type in the chat box. We'll take those. I want to ask, sir, Professor Tripathi, sir, uh, in clinical pharmacological reconciliation review and feedback, the CPRRF, the meticulous history taking stands out as a key strategy for identifying the drug-induced disorder. So could you discuss the role and importance of history taking in the diagnosis of drug allergy and how it parallels its significance in drug reconciliation process or prescription reconciliation process? Sir.
Yes, I think in your presentation today, the answer to the question that you have posed now, the answer lies very much in your presentation of today. Uh, in general, of course, in the reconciliation of treatment or reconciliation of medications, particularly when somebody is exposed to polypharmacy, multiple medicines at the same time simultaneously, then there might be many issues relating to a lot of safety concerns, and particularly when you think of somebody presenting with features, okay, resembling or indicating allergy, or more precisely indicating anaphylaxis, that could be because of food, because of environmental, because of stings, bee stings, or because of also medications. So it is all the time more important to narrow down the etiology, and one of the strategic way would be to take medication history. We know of this ABC. I'll extend it a little further of ABCDE. Uh, ABCDE is actually, A is for ABC is actually for the presentation, and also the attention that is to be paid for in management of the patients. The ABC stands for airway symptoms or airway issues, B for A for that, and B for breathing issues, and C for circulatory issues. And you have rightly mentioned all these features. Uh, but then if you expand it a little further, there is certainly some degree of disability for which the patient will be brought immediately to the emergency room, and that is D for disability. And the first thing you have to, as a physician, one needs to do is try to understand the exposure, whether, as this presentation is indicating towards some kind of allergy, okay, you need to also know about the exposure. It is important to know about the exposure because temporality is also important. You need to also understand when did the exposure occur, and then when this manifestation started, okay, because based on that you will try to decide whether it is type 1 or type 2 or 3, etc., or delayed hypersensitivity. So accordingly your management strategy will also has to be planned. So that's why history taking is so very important. And when you take the history, you also try to determine the risk factors also, as you have in your presentation. You have also said, like adolescents and the elderly, they are more likely to have a more serious kind of anaphylactic reaction, or more severe or more fatal kind of anaphylactic reaction. So from the history you can try to see with the age of the patient, okay. Past history also increases the probability of fatal reactions more. Somebody who gives a history that he has had similar kind of problem earlier also, and he gives a positive history that he is allergic or he is anaphylactic to this drug, and this time also you find that there is a recent exposure of this drug, so then you can, the chances of this diagnosis would become easier, and diagnosis would not be delayed. Then more specific diagnosis is possible. If the patient is suffering from asthma, otherwise comorbidity, as a comorbidity, or he has some other cardiac condition, cardiac disease, particularly the ischemic heart disease, etc. So in that case also they pose as risk factors. So by taking a good history, not only just medication history but otherwise in general, so you can also will help you not only diagnosing but also determining the prognosis, and also determining the management plan, deciding the management plan quickly, okay. Like you have rightly said that if the patient is already taking beta blocker, that is also going to have an impact on your treatment decisions, that whether you would be giving glucagon, etc., instead of or if in case of refractory anaphylaxis. Now, when you talk of anaphylaxis, you have rightly said that anaphylaxis is rather maybe should be considered as a progressive kind of disease. It's a dynamic kind of disease. Okay, so someone who has a past history is more likely to be again diagnosed to be suffering from anaphylaxis. And only one thing I think there is a need to highlight here. Uh, of course, that is a different aspect, not directly linked to the question that you have asked about the importance of history taking. That I think we have discussed right now. So far as history taking is concerned, if I summarize that taking a good proper medication history will help you in identifying the trigger, number one, in deciding the temporality, okay, and also in planning your management, because by that time you will be classifying whether it is really anaphylaxis or it is some other kind of hypersensitivity reaction, other kind of allergy. So that is important, because you cannot delay the treatment. Early diagnosis can only help you in appropriate treatment to be instituted early enough. So that is important. One thing apart from that, one thing I wanted to also highlight here regarding use of epinephrine. You have highlighted, and I need to reiterate that if it is anaphylaxis, the drug is adrenaline. The first choice is always adrenaline, and that also, again, you have pointed out rightly that try to give it intramuscular. Regarding the dose, it is 1 in 1000 concentration, and 1 in 1000 means 1 gram in 1000 ml. That is the concentration, and you give it depending on the age. You give it 0.05 in a very young child, okay, less than 5 kg or maybe 5 kg body weight. If it is 10 kg body weight, then give it zero point 0.1 ml of that solution intramuscular. If in case of adolescents, you give it zero point 0.2 ml. In case of adults, you give it zero point 0.3 ml. In case of pregnancy, you give it zero point 0.3 ml. So zero point 0.3 ml of 1 in 1000, okay, concentration, that is to be given. Now, regarding in adrenaline pain or epipain, I think it is now available in India, although it is not very popular, but there are some companies which has brought in the market. I do not know how easily it is available, but it is found that it is made available in India. uh, it is a very good uh, readily available tool, management tool. And in the Western countries, among school children, in all schools, it is made mandatorily available, so that the first management, one need not to rush the child to the hospital. And in fact, the first management can be done in the school itself by the teacher himself. Okay, uh, even if it is not very correctly diagnosed, uh, 1.1 ml of 1 in 10, 1 in 1000 adrenaline intramuscular is otherwise not going to have much of the very serious adverse reaction in the child. So that is the reason why this EpiPain has been made so very popular in the Western world. Unfortunately, it has not been made easily available or not made very popular here. Now, refractory uh, anaphylaxis, what we have also mentioned, how do you define refractory anaphylaxis? It is, there are many definitions, but one of the workable definition is if a patient requires more than 2 doses of the prescribed dose, that is intramuscular zero point 0.1 or zero point 0.2 or zero point 0.3 ml of 1 in 1000 intramuscular, and the symptoms are not reversing, then you can consider that it is refractory. And in that case, you have to perhaps give intravenous treatment. So, as you have mentioned that it fails, adrenaline fails, but then uh, there are also authorities which say that you can also think of giving intravenous epinephrine, of course, with appropriate monitoring. Okay, and you can go for, and particularly chance of this refractory anaphylaxis increases when the exposure history is with parenteral drug. And as we know, the drugs that are more commonly known to cause drug anaphylaxis, that is drug-induced anaphylaxis, are of course penicillins, as well as non-steroidal anti-inflammatory drugs, and some of the antibiotics, and some anti-cancer drugs, radio contrast media. So these are some common kind of radio contrast media. We have checked in the radio contrast media which is used in the radiology department, but to what extent in the emergency tray epinephrine is readily available, that is again something one can try to check and see. Many a times it is not available very easily in the emergency tray around. Okay, one should play cautious there. Regarding the another variant of drug induced anaphylaxis, although it is to be expected to be appearing in minutes or maybe within hour, but sometimes it may be a little delayed also, maybe a couple of hours also. And in case of protracted or prolonged, you have rightly mentioned, it can also go for more than 24 hours or even sometimes 48 hours. And you have correctly mentioned about recurrence or a relapse even after 48 hours, which could also be life threatening, that you have mentioned. And that kind of variant of anaphylaxis, although that is not very common, but that is also called a biphasic kind of anaphylactic reactions. So these are the few things I thought that I can mention. And when you say adrenaline uh, can also have an impact on the beta blocker. If somebody is receiving beta blocker, then adrenaline being with surmountable uh, antagonism with the blocking agents, with excess dose of adrenaline, that can be also uh, taken care of. And besides, as the symptoms are not improving, then in the second level of treatment is actually antihistamines and the glucocorticoids, as you have mentioned. For the bronchodilators also you can use the beta stimulants over there, that also you have mentioned. So these are some of the comments that I wanted to make. Thank you. Over.
Thank you, sir. Thank you for your extremely important take on this. And as we were mentioning about glucagon, sir was mentioning about glucagon, and there was one question also asked in the chat box. You can see how the glucagon should be given and when, at least, when we should think of starting glucagon. So actually, if the patient is already taken 3 doses of adrenaline and there is no response, uh, each dose have a 5 minutes interval, so 15 minutes passed, but the patient is not at all improved, and we know we get the knowledge that patient is on beta blocker. So that is the time we should start with glucagon, because if we start glucagon, that will reverse the refractory bronchospasm and also the hypotension. And as already we had discussed, the dose is generally 1 to 5 milligram, and this should be given intravenously over 5 minutes, and then followed by, if required, we need to start infusion glucagon 5 to 15 milligram per minute rate, and we need to titrate that dose according to the clinical response. But again, we need to keep in our mind that protection of the airway is very important when we are using glucagon, because this will definitely cause emesis, and the risk of aspiration will be there. So we need to make them in a lateral recumbent position. So these are very important issues. And I think, again, the question.
This is, I think, it would be important to mention here, because glucagon acts through non-adrenergic pathway, as you have mentioned, by stimulating adrenaline cyclase. So it can act synergistically with adrenaline.
Yes.
So when in case of refractory anaphylaxis, you can think of using intravenous adrenaline as well as glucagon, because adrenaline is ready at hand. You can also think of, but then remember, when you are giving intravenous adrenaline, it is not the same strength, 1 in 1000. So it has to be at least 1 in 50,000 or so. And then you have to also monitor the heart rate and the blood pressure when you are using intravenous adrenaline. But the advantage of using glucagon along with adrenaline is that there is synergy of both these two drugs acting together. The advantage with glucagon is also the beta blocker uh, uh, induce the tendency towards hypoglycemia can also be taken care of. Otherwise, it can also take care of uh, the other symptoms of anaphylaxis. It is also considered as a choice in case of resistant or uh, the refractory anaphylaxis also. Over.
True, sir. So there is one question regarding the, uh, I think the dose of adrenaline, and I think Professor Tripathi also had discussed about the dose of adrenaline in details. But sir, one thing is that you had told about the EpiPen availability. Actually, sir, EpiPen is available, but we need to buy it from outside. Like nearest,
Okay.
the Singapore is available. So online we can buy EpiPen, and that cost around maybe 4,000, 5,000 rupees INR. But that need to be bought from the Singapore. What we generally recommend our patient who is suffering from anaphylaxis and there is a chance of anaphylaxis in later. So we actually tell them, ask them to have one is to 1,000 adrenaline, uh, that is ampule, and take in one tuberculin syringe. We know that tuberculin syringe, they have a needle for internal muscular injection, and we can take 0.5 ml of adrenaline in that particular tuberculin syringe. And we ask the patient to keep this in a covered way. Do not, there is no need to keep it in refrigerator or anything. Keep it in any cool place of your home where the adrenaline should not be exposed to any direct sunlight, because we know by exposure to sunlight, the chemical nature of adrenaline becomes altered. So often we have a very small box of our glasses, spectacles. So we give them that spectacle box, and the 0.5 ml is measured and keeping that particular spectacle box covered way. So there is no sunlight exposure, no hot exposure. A uh, cool area is often good. And the children can also carry that in their bag. Only thing is that they need to take care of the expiry issues and things. Yes, obviously the question arises because as we are making it out from the ampule, so the sterility is a question issues. But the thing is that as we do not have anything now, we need to arrange some makeshift. So this is one type of makeshift arrangement uh, to to save our patient's life, because as already we had discussed how it is important to administer adrenaline at earliest. So this is the thing we actually do. So the dose of adrenaline, as you are asking, in general, it is for adult population, it is that 1 is to 1,000, that is 1 gram in 1,000 ml solution of the ampules. And we need to give 0.5 ml from that particular ampule to our patient intramuscularly in the vastus lateralis. And uh, that is the recommendation. And we should administer it every 5 to 10 minutes interval as necessary, as soon as the diagnosis of anaphylaxis is suspected. I think this is one question that has been asked by one of our delegates. May I ask, sir, now as you are also a very noted clinical pharmacologist, sir, so in the context of drug-induced anaphylaxis, what are the current challenges in identifying the risk factors and managing the safety profile of new pharmaceuticals, new drugs during the development process? Because we all know that the clinical drug development process, we do not have that much data. So how much it is important to give stress on post-marketing surveillance, specifically when we are talking about anaphylaxis. So what is your take, sir?
Yeah, the currently the in the pre-marketing development phase, uh, the chances of potential for drug anaphylaxis is hardly identified, because as such the for the anaphylactic manifestations there are different factors that are responsible. Most important probably is the host factor. uh, Regarding the drugs or the uh, otherwise instead of uh, the active pharmaceutical ingredients, the excipients, they can also, if, they can also pose as an allergen or as an antigen. But then in the drug development phase, okay, in the different drug development phase, particularly pre-marketing, pre-clinical drug development phase, uh, the structured uh, methods for identifying the potential for allergic reactions, okay, it's routinely what is done for any drug. Okay, there are no special kind of experimentation whereby the potential for allergy could be are actually eliminated. I mean the type 1 reaction, at least anaphylaxis. The only thing that remains with us is occasional or the rare possibility of identifying 1 or 2%, okay, during the preclinical phase, if they come out with and present with a reaction which can be marked as type 1 reaction. That is only by mere chance. But then after the drug is marketed, it is only then one has to be vigilant, and one has to depend on a good robust post marketing surveillance system, whereby one can think of finding finding an association between a new drug that is marketed and its potential for causing anaphylaxis. Up till now, whatever classes are already known, like penicillin, cephalosporin, sulfonamides, so these kind of antibiotics, as well as the non-steroidal anti-inflammatory drugs, there are some anti-cancer drugs, etc., radio contrast media. So these are some of the drugs which are otherwise known to have higher potential to cause anaphylaxis. And any new drug that has any resemblance to the structural or otherwise resemblance with these drugs, they are to be particularly looked into whether they are producing any anaphylactic reaction in the post-marketing surveillance studies. So this is one thing that we have to keep in mind. And reporting is also important. It is ultimately it is the attitude of the clinicians when they come across any such reaction. Okay, like so far as India is concerned, we have a platform, we have a national platform of reporting, and that is the pharmacovigilance program of India. So it is the clinician who need to report them, notify them to this platform. Then only there will be a national database uh, that will be found. Excepting the chemical agents, the biologicals, they have a higher potential to cause anaphylaxis. Particularly, more and more we are having newer monoclonal antibodies. So they, as compared to the chemical substances, the biologicals and monoclonal antibodies, they are might be having relatively greater potential for causing allergies and anaphylaxis. So one should be more cautious when using these agents to try to find any association between their use and possibility of anaphylactic reactions and reporting them to the proper platform. And thereby the national database will be created, and as necessary there might also be the need to change the level, and whereby we also come to know that which products are having a greater risk of causing anaphylaxis. Particularly, when you are using, you have to keep in mind the different other risk factors and try to eliminate those risk factors as much as possible, and thereby the possibility of reducing the scope of these reactions will be considered. There is definitely role of allergen immunotherapy in managing these kind of allergies, drug allergies. I think there will be a series of other sessions also to discuss the importance of allergic immunotherapy. But uh, today also, whatever we discussed from there, we find there is a uh, role and how they can affect the mechanism of pathogenesis of the different allergic reactions that has been discussed. So that would help us in understanding the role of allergen therapy also, which maybe in greater detail will be discussed in future classes. Thank you.
Sir, you are on mute, sir.
Thank you,
You
sir.
need to you need to unmute, yeah.
Thank you very much for your response, sir. So as we are approaching towards the end of today's session, once again, I am requesting you all to finish your post-test. That is given in the by your mail. I think Imazika can confirm whether they can send the mail again for the post-test. And we also talk about different aspects. The one or two questions that have been given here by our technical team, that is, may I know which text and author to be referred for allergen immunotherapy? So always it is better to go by the classic textbook like Middleton's Allergy. I think all of you can know about this book, which is very famous one, Middleton's Allergy. But at the same time, when we talk about allergen immunotherapy in Indian context, I think we will share with you all the current guideline on allergen immunotherapy in India that has been published by Patel Chest Institute, New Delhi. We will share with you all the current guideline on allergen immunotherapy. Another question asked, that is for chronic recurrent nasal polyps. What is the current status of immunotherapy with elevated Ig and AC? So we will discuss again the indication of immunotherapy, allergen immunotherapy in details. But one thing from this particular lecture, which I want to emphasize again and again, it is not that elevated IgE is equal to allergy. So many times we'll get patient where IgE is normal, but the patient will have allergy. Many times patient will have very high IgE, but the patient is not suffering from allergy. So we should not confuse on the IgE value or even the absolute eosinophil count values. We need to emphasize again and again the importance of history taking in allergen immunotherapy. Another question asked, that is why small family size is attributable to risk factor. Obviously, the hygiene hypothesis, similar like hygiene hypothesis, if we have small family size, we have small interaction in between the babies, and that is responsible for a shifting towards the Th2 response rather than the Th response. I think we had, there are many questions asked on adrenaline and anaphylaxis, the dose, when to give glucagon. So we have discuss it in details. And
Dr. Shambho, can I just address one question? There is apparently some confusion probably. Dr. Smita Satpathy, Bhubaneswar, she
yes, yes,
has asked that dosing in children as taught earlier 0.01 ml per kg, milliliter per kg, maximum 0.5 milligram. Now it's fine. You can think of 0.01 milliliter per kg even for at all age groups. Now, if it is 0.01 milliliter per kg, if it is a 5 kg child, then it becomes 0.05. If it is 10 kg child, it becomes 1 ml. So 0.1 ml of 1 in 1000. And then if it is 20 kg, maybe an adolescent girl or boy, then it becomes 0.2 ml. And accordingly, you can go for 0.3 ml, zero point 0.4, zero point 0.5. Usually in adults, it is the standard first dose is 0.5 ml, and you can repeat that after 5 or 10 minutes if the symptoms are not improving for 2 or 3 doses. Even after 3 doses, if it is not really responding all the symptoms, then probably you have to think of whether it is uh, you have to think of whether you need to give glucagon or you have to give intravenous adrenaline. So that means if you give 0.5 twice, it becomes 1 ml actually, 0.5 ml twice. So 1 ml of 1 in 1000 is the strength. So, but then remember, when you are switching from intramuscular to intravenous, the strength should change. So intravenous, it is not, that will be too strong concentration to be given intravenous, 1 in 1000. Then in that case, you give 1 in 10,000 or 1 in 50,000, like that. So that is about the dose. When you say that 0.01 ml per kg, you are right in case of child, and but then you are going ahead with the per kg body weight. So accordingly, what we have said and what you are saying that it is taught as like this, there is no discrepancy otherwise. So regarding adrenaline longevity, yes, it is a matter of concern, because as you know, adrenaline, if it is not stored properly, then it loses its effectiveness. And the easy thing is to see whether the transparency, the transparent fluid, whether it is tending to turn yellowish. So they, you know, that they convert into adenochrome, and as the adrenaline solution turns yellowish, that means it is getting denatured. So as it gets denatured, the chances of effectiveness will be relatively reduced. So you are not, it is not very reliable, and that is the reason that the adrenaline ampules are to be kept in the right storage conditions, away from the direct light or away from temperature, heat. So that's some of the other issues to be discussed, and I
and
think that I wanted to highlight that. That's it.
thank you, sir. Another issue is that one thing we often face in emergency, because there is an availability of very common antihistamines, that is promethazine. So it is better to avoid promethazine, and it should not be used in anaphylaxis. Why? Because this will definitely worsen the hypotension, and also that will cause muscle necrosis. So please do not give promethazine. Yes, you can use diphenhydramine as an H1 antagonist, but don't give promethazine. And before
Okay.
moving to intravenous adrenaline, we need to use, as already we had discussed about glucagon and the volume correction. So when we talk about fluid resuscitation, that also need to be considered, because even in beta blocker users, they require this large volume of fluids, and especially when the hypotension persists, so they require intravenous crystalloid solutions or sometimes colloid volume expanders. Of available crystalloid solutions, saline is always normal saline is generally preferred, because we know from our undergraduate days in distributive shock, that means in anaphylactic shock is one type of distributive shock. So there, this is always better because it stays in intravascular space longer than the dextrose and contains no lactate, which may potentially exacerbate metabolic acidosis. So lactate can cause metabolic acidosis and worsen the situation. So normal saline is always the best volume replacement agent. So these are few important issues I think we had discussed. And
Dr. Bagchi has posed some question, and that is, can intravenous adrenaline in refractory case, even after 3 doses of intramuscular, is it safe, as it may accurate cardiac compromise in cardiac compromised patients?
yeah,
So yes, there is a issue there. If there is already known cardiac compromise, then use of intravenous adrenaline is to be done with due caution and all the time. That's why I'm mentioning that whenever you think of using intravenous adrenaline, you have to continuously monitor and monitor the drip rate, the strength of the solution, as well as the uh, indicators of, like, you have to also monitor the blood pressure and heart rate simultaneously. So under constant monitoring, you can use intravenous adrenaline, but then the dosing is also to be continuously uh, checked. Okay, the drip rate also, particularly if there is already history of cardiac compromise. Interestingly or unfortunately, with glucagon, that kind of concern will be definitely much less. Regarding the other thing, selective beta blockers, when the patients are on beta blockers, whether selective beta blockers will also pose equal problem, at all problematic. Definitely, it will be less problematic than non-selective, but that doesn't rule out that it cannot pose any problem, because we know, although we are talking of selective beta blocker, but many a times that selectivity is only relative selectivity. So there might be also issues with so-called selective beta blockers. So that is also the other thing. Uh, the other question was, when patient is admitted, we administer many drugs in similar function. How to identify which drug causing anaphylactic reactions? Again, temporality and pharmacological plausibility. If the patient is taking 5 drugs, any of them is already known to have anaphylactic risk, is to be suspected first, and then when was that drug given. So temporality. So these two things, pharmacological plausibility or existing knowledge about its potential to cause anaphylaxis, and the temporality. So these two factors will help me to suspect whether a particular drug is suspected to be causing anaphylaxis. So that is the other question. So that's it. Thank you. Over.
thank
Dr.
you,
Sam.
sir. Thank you. There is another question asked, that is post-viral bronchitis. What type of allergy? So actually, when we talk about post-viral bronchitis, that is not an allergy. But if we talk about post-viral bronchitis, is which type of hypersensitivity reaction? So yes, this is a type 4 hypersensitivity reaction, which could be due to those interleukins, those cytokines, which are resultant from the immunological antigen antibody reactions and differentiation of the T cells. So we can call it as type 4 hypersensitivity reaction, but it is not a post-viral bronchitis, is not at all a allergy. And another question, I think that has been, I think all the questions had been addressed.
Did you mention, Dr. Shambhu, about that type 4 reactions and drug induced type 4 this thing, and with Steven Johnson's and 10? I think maybe in some other sessions here will be discussed.
Yeah,
That
already we had also had shown one slide on different types of type 4 hypersensitivity reaction, and there is one type 4 C reactions, that is the cytotoxic T lymphocyte mediated activity, that is CD8 T cells becomes hyperactive, and that may result in this Steven Johnson syndrome like issues. So we have a lot of discussion, and again I am really thankful to Professor Shantanu Tripathi sir for staying with us for almost long, more than 2.5 hours almost. And I am really sorry due to of my little bit infection. My throat is not that good. Most probably I had not done the justice to this topic due to my voice. So I apology for that. But again, I request you all to be present in the next class. And I think all of you have the schedule of next class. So that will be on the next Sunday from 10 a.m. sharp. We will start the session. So thank you. Thank you once again for your patient hearing. And thank you once again, Professor Jyotirmoy Pal, the Dean ICP, for this wonderful initiative of having different short type of certificate courses on this is the allergen immunotherapy course. Like that, there are many other short certificate courses are ongoing under the banner of ICP, that is Indian College of Physicians. So thank you, Professor Jyotirmoy Pal. And also I want to thank Professor Girish Mathur sir, the president of API, for providing us this platform. So thank you all the delegates.
Dr. Shambho, before you leave, there was another question. Anita Krishnan, Bangalore, asking 75 kg man, the adrenaline dose is 0.5 milliliter. Query. Answer
Yes.
is no. But then as a first dose, you can always give 0.5, and if it is not improving, then within 5 minutes you are giving the second dose. And even after that, the third dose. So there should not be much of a concern. If you take a thumb rule, all adults will be giving 0.5 milliliter as the first dose. It is only the first dose. And within 5 minutes, you give the second dose and
Yes.
maybe the third dose also. So there should not be any confusion for that matter. Okay.
So 0.5 ml is the highest dose we can give. So we can give 0.5 ml, and that can be repeated after 5 minutes. So
Right.
that is the question. And 0.5 million of here, the answer should not end with 0.5 ml.
Right.
0.5 ml of adrenaline in bracket 1:1000. 1 gram of adrenaline in 1000 ml of adrenaline solution. From that, we need to give the 0.5 ml of adrenaline. So once again, thank you all. I think post whether I am just again requesting Imagika Health to please send the post test evaluation to all our attendees, whether you had shared or not. Can you confirm, Himangshuji?
Yes, I'll send the post question link already to all the attendees.
So please send all of them the post test evaluation sheet. We'll wait for their answer because today is the first day. We'll definitely wait for their answers for longer duration. So thank you once again for staying with us in this Sunday morning, and we are waiting to meet you all in our next academic session on the 12th of November from 10 a.m. Thank you, Tripathi sir. Thank you all.
Thank you, Dr. Shambho, and thank you all.
Thank you.